Hey, we'd like to welcome everyone who's joined us today for our webinar. We appreciate you coming in and taking the time to be with us. I'm excited to introduce you guys a company that I've come to know and worked with. But a little background on Win Medical for some of you may be new. I've been in the interventional pain field for about 30 plus years, and I sell equipment, supplies, regenerative medicine products, and ancillary programs. And when I come across something that I feel is beneficial to the people that I've been working with over all these years, I like to throw it out there and introduce it to you guys to have you evaluate it and look at it something that would be that added value to your practices. And Genesis, I believe, has gone a step and beyond in the toxicology world to help you to work with your patients and in the diagnostic space. So with no further ado than that, we appreciate you being here. We're going to turn the time over to Nicole, who is the CEO of Genesis, and she'll introduce our speaker today. Nicole, it's all yours.
Thanks, Brad. Thanks so much. I'm Nicole Moberg, like Brad said, CEO of Genesis Reference Laboratories. We're located in Orlando, Florida, and we just recently opened up our newest laboratory in Colorado, which we're very, very excited about. But we're equally excited about the opportunity today to share with you our VP of Medical Affairs. And it's also a very exciting educational topic for us and one we're very, very passionate. But I want to introduce Scott, and we won't hold this against him, but he is a Florida Gator. So I'll start with that much. But kidding aside, he went to the College of Pharmacy at the University of Florida, and he started his career in the Veteran Affairs area. He did that for over 10 years as a clinical pharmacist and then in palliative care. And he was very involved in the clinical training of pharmacy students as when they were first year graduates. And he also developed and oversaw ASHP accredited second year residency for pharmacists. And then he went into pain and palliative care. The part that is more relevant to this is then he transitioned into the pharmaceutical area, where he was a scientific liaison in the diagnostic space with a laboratory specializing in toxicology, then moved into an MSL role at a smaller pharmaceutical company, and then back to where he is today, which is with us as our VP of Medical Affairs. And I just want to say a few things. He is not only a staple at Genesis, he helps us develop and build our offering. He also educates internally and also educates externally, and is just a fantastic resource for our customers and prospective customers. So without further ado, very excited to have Scott educate you all today with a topic we're very passionate about. So Scott, I'm handing it over to you.
Thank you, Nicole. I am going to share my screen now. So as she said, I am a pharmacist by training and a Florida Gator. And so that's where I'm from, where I'm based out of. Work with this lab in Orlando, but covering us across the country. And I'm going to talk today about some toxicology testing and ways it's incorporated in clinical care. Some of the, some nuances that I've learned over the years that I first started discovering when I was doing clinical work as a pharmacist, and realize, again, some of the nuances associated with toxicology testing. And then, of course, once I started actually working in that area, devoted a lot of my time to it. And so it's become a specialty of mine, and I am excited to share this. We will be taking questions, run through them at the end. You could submit them. They're online. And let's see, we'll get the slides going. All right. I am assuming you guys are seeing my slides now. Just disclosure, obviously, I am employed by Genesis. A lot of things I cover are very general, but there are a few things that we'll talk about that are specific to us. But these concepts, again, are true across the industry. Some of the objectives today is to gain a basic understanding of toxicology testing and the clinical value associated with it. And how we'll do that is by looking at some of the key differences in the types of toxicology testing, which I think is probably the most important thing that we can discuss. And then we'll have quite a few what I consider common topics like false positives, false negatives, validity testing, looking at different testing matrices, and then we'll actually get into a little bit about ordering and interpreting toxicology results. Some of the terminology we'll use, UDT, which can be urine drug test or urine drug toxicology, oral fluid testing, or OFT, oral fluid toxicology, where we use saliva instead of urine, point of care testing or POCT cups. Then we get into some of the really fancy words, the LCMS or liquid chromatography and tandem mass spectrometry, and then its gas counterpart with gas chromatography. Limit of detection may come up, and that is where we usually consider our cutoff or the lowest concentration of an analyte that we can be confident in detecting and confident in reporting a quantitative value. And then also window of detection is something that comes up a lot, where is the time period where we are confident in detecting a substance following its use. A lot of stuff we'll be covering later, like presumptive or screen, definitive and confirmation. Reflex testing is something that may come up. We'll talk about what some ordering options could be when you go to look at ordering. And this usually refers to additional testing that is done based on a particular result in order to improve the understanding of a situation, to dig a little deeper into finding out why a result actually occurred. Like I said, false positives, false negatives will cover, as well as validity testing. So very generally, what is urine toxicology? Well, it's the testing of a urine sample for the presence of drugs and or drug metabolites. Now, it's not without its limitations. Urine toxicology cannot tell us how much drug was taken, if the patient has an addiction, or just that the patient has been exposed to or ingested or absorbed that substance relatively recently. And I say relatively recently because it's very highly variable. Some substances have a very short half-life and are only recognizable for less than 24 hours. Things like 6-MAM, which is a unique metabolite of heroin, or things like benzoyl-L-gonine, which is a metabolite of cocaine. Other ones can stretch out more than 2 weeks. So chronic users of methadone and diazepam, you can detect it in urine for weeks. And now we have some that are even over a month. So chronic heavy use of marijuana, you can often detect it for over a month. We are now learning that fentanyl at the doses that are being taken in the street is detectable up to 30 days. There are some case reports around 30 days of being able to detect fentanyl or its metabolite. And then we have a lot of now injectable depot forms, things of some of the long-acting antipsychotics, some things that are implanted like Sublocade, which is a buprenorphine pellet that is put in for an extended release. And those have been shown to be detectable for up to a year after a couple of doses. Now, there are also differences in how individual people metabolize and excrete drugs, and this makes it really impossible to know for sure when a drug was taken or how much. As an example, I'll say a level of 250 nanograms per ml in urine would mean very different things for different people, and there's no way to tell if this result was because a small amount was taken 12 hours ago or a large amount was taken 3 days ago. So this cannot replace blood therapeutic level monitoring, but it can give us a very good look back, in general, around 3 to 5 days, I would say, for what a patient has taken or been exposed to. It's evolved a lot, though, since, I would say, since the 70s and 80s, when drug testing became very commonplace. And I like to think of it as back then, it was usually a screening for employment, or it was court-mandated testing. It was often a forensic tool only, and results were punitive. The focus was on illicit drugs. Can be known as like the Federal 5 is the most basic testing we do. And it was something that was done to the patient. Now, with a lot of the improvements in technology and the understanding of drugs, drug metabolism, and how we handle things, it really can be a tool that positively impacts patient care in a lot of different therapeutic areas, especially when we can focus on monitoring of sobriety or therapeutic substances. And it's really something done for the patient now, as opposed to something that was done to the patient. And a lot of people can benefit from it. So basically, anyone that's interested in monitoring adherence, so is the patient taking the medications they're prescribed? Is the patient taking medications or substances they are not prescribed? The most common things and the easy ones we think about are substance use treatment. So with people in recovery, testing for relapse, what they're taking now, in pain management, where we have even the CDC guidelines recommend the use of toxicology when you have chronic opioid therapy. obstetrics. They are usually testing in high-risk patients because of the incidence of neonatal abstinence syndrome. You need to be sure that an expecting mother is not using substances. It gets down to primary care now and to some psych where you may not be giving out high-dose opioids. You may not be dealing with a patient that's in recovery, but you're often using controlled substances still that can be diverted. In behavioral medications, you could have your stimulants for ADHD use. You could have benzodiazepines and those other things. And then, of course, just for mental health treatment, because it has such a low adherence rate long-term, you want to monitor that. But if we really open up the big picture, patients are also people that can really benefit from it. And we'll kind of touch on some of the ways that can happen later on. So I mentioned a large dichotomy in testing, and really it comes down to, is it immunoassay and presumptive testing versus a confirmatory definitive testing like liquid chromatography. Have some pros and cons of each. With immunoassay or presumptive, if you look on the left side, it is a qualitative test. So you're going to get a yes or no response there. It's usually done in the office or with a point of care device, but it can be done in a lab. Results are within minutes. And this is the big advantage with a point of care device or an immunoassay test, is you can have it while you're speaking with a patient and have those results to talk to. Some of the cons, though, is they're only designed to detect a few select substances within drug classes, and they have a low specificity, which can lead to an incidence of false positives. And they also have low sensitivity, which can yield false negatives. On the other hand, with liquid chromatography or another confirmatory method, gas chromatography, the results would be quantitative. So your result is now a number, a measured amount of how much of a substance was in the urine or the oral fluid. However, it is done in laboratory only, and results do take longer, often many hours. And so it's not something you're going to get back usually the same day you test. So it's nothing you can handle and start a discussion with a patient while you're seeing them. Benefits, though, it can detect a wide array of parent drugs and metabolites and has very high specificity and high sensitivity. I don't like to use the words always or never, so I will say very rare to have a false positive or a false negative. This would be an example of a very common 13-panel point of care cup and what the testing menu on it would look like. So they would have, needs to be CLIA waived to be able to use in patient care, and would have things like amphetamines, barbiturates, buprenorphine, benzodiazepines, cocaine, methamphetamine, MDMA or ecstasy, opiates, which we'll actually dive into a little bit more specifically about what that means when it says it tests for opiates. Also methadone, oxycodone, PCP, the tricyclic antidepressants, and THC or marijuana, which these also detect a lot of the semi-synthetic marijuana variants that are becoming more popular and are quasi-legal in many states. What we didn't mention was fentanyl. And fentanyl, of course, is a drug of very high concern because of its prevalence in the illicit drug supply and the very high volume of counterfeit pills that are just pervasive right now, with dealers having gained access to pill presses and making counterfeit tablets that look very much like the prescription drugs out there, but they contain fentanyl. There is now one company that has an approved fentanyl test device. But if you're looking for a fentanyl test strip or something that can do a test for fentanyl in your office, be very careful, because most of them are not FDA cleared, CLIA waived. They are labeled for forensic use only. This particular screenshot, they actually have it in red print. It's pretty upfront that it is not CLIA waived. Other ones are not so upfront. And so it'll be fine print somewhere that it says forensic use only. Well, what does that mean? Well, forensic use only would mean that, this is an excerpt, the top from a package insert saying that their tests for tramadol, synthetic cannabinoids, ethyl glucuronide or ETG, and fentanyl are forensic use only. And this means it's intended to be used only by companies that are using within the criminal justice system. So companies and users that are allowed to use these would be like law enforcement, probation, parole, correction centers, and the military. You're not allowed to use these for patients because they are not FDA approved. However, there now is finally one out there for fentanyl, but still there are cups and other substances like tramadol in these that there is no approved cup for those. What we're going to look at now is actually some excerpts from a package insert. And as a clinician, this was the first really eye-opening thing to me when I started getting results I didn't understand and that disagreed with the confirmatory testing. I started looking at the package inserts. And the highlights are mine, but similar language will be found in just about any package insert I've ever looked at. And it's pretty interesting that they will say that this test is preliminary, and the positive result does not always mean a person took illegal drugs, and a negative result does not always mean a person did not take illegal drugs. In the next blurb, the result you obtained is called preliminary for a reason. This sample should be tested by a laboratory in order to determine if a drug of abuse is actually present. Send any sample which does not give a negative result to a lab for further testing. And then another blurb. This test provides only preliminary test results. A more specific alternative chemical method should be used. GCMS is the preferred confirmatory method. They say that because this is old. We'll look at the differences between gas chromatography and liquid chromatography in a slide here coming up. But they say that clinical consideration and professional judgment should be exercised with any drug abuse test, particularly when a preliminary result is positive. If you read further, they had an FAQ section in there. Question 6 was, if the test results are negative, can the conclusion be the person is free of drugs? And they say probably none of the drug screen was present. Question 7 was, does the preliminary positive mean the drug abuse has been found? And again, they say you need to send this to a lab for a more accurate test. At this point, you're probably like me and wondering, why are we doing these in the first place? Because of its accuracy. The biggest reason is because you have at least something to begin there. We would call them conversation starters. We had something we could begin to discuss. On the right is a graphic just showing this, and if you work with this, I'm sure you've noticed it. However, I have had issues where people would misread this because it's not common sense and intuitive. A positive, the test line is not there. So if the test line shows up, it's negative, which is opposite of most of the tests that you're doing for other antigens or antibody tests. Most rapid tests, if the line shows up, it's going to be positive. However, it's reversed here. And this is because the technology used is called competitive assay. And what we're going to look at here is an example of how competitive assay works. So what you'll see is on the left-hand side is this would be a test strip. When we break it down and talk about what is actually contained in a test strip. So you would have the sample area where this is what you would put into the urine or apply the urine to. The next section would have a series of antibodies. In this case, the blue Ys would represent a lorazepam, so a benzodiazepine, a lorazepam antibody, and the red circles are a gold nanoparticle that is part of this. Then further down, you would actually have the test line, and this would have a benzodiazepine or a lorazepam antigen there to hopefully bind to that antibody. And then further down than that, you would have your control line. This would have a secondary antibody that was meant to collect the gold nanoparticle that is attached to that blue Y or to the lorazepam antibody. So if you have a sample that has that substance in it, so you can see represented by the white drop with the green dots in it there, so that would be lorazepam in a urine sample or in an oral fluid sample if you were doing immunoassay. When it is applied to the test strip, that lorazepam would bind to the antibody, which is represented by the blue Y. Therefore, it could not bind to the test line. It goes by the test line because there's not enough of the blue Ys that can bind to it to make it show up. And it's gathered in the control line. And so no test line shows up, control line does. That is a positive test. In a sample that does not have any of the active constituent in it, so no lorazepam in this sample, there is nothing to bind up the lorazepam antibody, the blue Y. Therefore, it can bind to the test line now and bind to those antigens. There's still enough to bind, enough of the extra particles there to bind to the control line to set it off. And so you end up with a test line and a control line. And so that would be your negative immunoassay test result. Where we come into problems, though, is that often these antibody antigens aren't an exact match. If they made them to where it had to be an exact match, the level that you would have to get a positive goes much higher. So we're left with false positives. So a false positive is simply a positive result that is false. And this is an example that I saw multiple times as a clinician when I would have a 70-year-old male vet that was positive for PCP. yes, we have to go talk to them and say, is there anything you'd like to tell me about? We had some strange results on your urine tests. And they'd say, oh, no, nothing I'm doing. Like, well, it was PCP positive, and usually you get a good laugh out of it. Send it for confirmation testing, and of course comes back negative. The reason this was happening is we were using a lot of Effexor or venlafaxine, and it just so happens that one part of the venlafaxine molecule looks very similar to one part of the PCP molecule, and this similarity is enough that the puzzle pieces can bind. So it would bind to that blue Y, carry it past the test line, and then it would show up as a positive, but of course would not actually be a positive. Now, the other side of this coin is a false negative. So just like this, a negative result that is false. In this example, if you had a patient that was prescribed hydrocodone, so they were taking Vicodin, prescribed 2 tablets twice a day as needed for pain, you wanted to test them to say, are you taking it or are you diverting it if they say they've been using it? Because a negative result on an opiate strip could be construed as something where they're not taking what you're prescribing and could cause issues. So in this case, the test was negative, even though confirmatory testing revealed a level of 500 nanograms in the urine. And this was an opiate 300 strip. And the reason this is that how the opiate strip is designed is to detect the natural opiate molecules, morphine, codeine, heroin. And it does it's less sensitive and less able to detect other ones, the more manipulation of the molecule there has been. So this is again, a screenshot on the left from a package insert of an opiate strip that is designed to detect opiates at a level of 300. And you can see the ones I mentioned, the ones it's actually designed to detect, it will detect at a level of 300 nanograms. But as we get into the semi-synthetic ones, hydrocodone, the level needs to be 5,000, so 15 times the concentration of what's stated on the actual label. Oxycodone, which is again a little bit further away in structure, would need to have a level over 80 times that 300 in order to be detected. What you won't see on here are things like buprenorphine, fentanyl, methadone, tramadol, tapentadol. You won't see them because no matter how much was in the urine, they are so structurally different that they cannot trigger that opiate strip to turn positive. So you could actually have someone with lethal levels of fentanyl or methadone or tramadol that would not turn positive on an opiate strip. And that's sometimes the difference between an opiate and an opioid. So this is why you'll see a separate test for a lot of these. So if you think about the panel we talked about, that 13 panel, it had a separate test for oxycodone, for methadone, for buprenorphine. And then, like I said, we now have ones for fentanyl because an opiate test strip will not detect them. So closing up on this stuff about false positives and negatives, I always say, remember that immunoassay, while it has its benefits, is only a qualitative test. So the result is simply a yes or no. False positives and false negatives are not really errors or mistakes by the test. The test is still working as designed. It's just not a great clinical tool. Or to quote one of my favorite movies, 60% of the time, it works every time. So these are some of the limitations you really need to know about with immunoassay when you're using it on your patients. Now, you can use immunoassay that's not point of care tests there. You can have it in the lab. So for instance, we have screens that we could run for fentanyl, for tramadol, for LSD. It's important to note that these are on an analyzer, so they're actually less specific. So we mentioned sensitivity and specificity. These are less specific, and while that initially sounds like that is a lesser quality, if it's less specific, it actually means that we are more likely to detect the related substances. So hydrocodone is more likely to show up on an opiate test when it's done in a lab. So we would have fewer false negatives on an opiate there, but it also means that we could pick up some things. We could pick up oxycodone and an opiate and on an oxycodone strip. Now, the other side of this, away from the immunoassay side, away from the preliminary side, is our definitive and confirmation process. And this one that we use is probably the most common now in the top laboratories, which is liquid chromatography and tandem mass spectrometry. It's a very scientific process that I am not going to break down everything that goes into it. There's no need to do it, and we don't have enough time. But this diagram, so the urine is basically cleansed. It is put through a column that helps separate out each individual analyte. So then it can go through a mass spectrometer, which actually weighs the molecular mass of these molecules. And then it takes a very skilled reviewer and reader to look at the data coming off, to look at things like an ion ratio and the retention time, compare it to internal standards that are run with every plate, and to identify where things are against our known standards. It is a quantitative test, so we get an actual value. It is very rare to have false positives and false negatives, and therefore it becomes a little bit more difficult to beat the test for reasons that we'll talk about in just a minute. But I still want to talk about a little bit of the difference between GCMS and LCMS. So gas chromatography is basically the same process, but you have to convert the urine or the analytes into a gas. And this can be more time consuming, and you have the potential to potentially lose some analytes during this conversion. And this is not us saying it. This is actually CMS. So this comes from a Medicaid, Medicare document that compares the differences when talking about urine drug testing and toxicology. And even they say that liquid chromatography compared to gas chromatography is about 100 times more sensitive and selective. It involves fewer human steps, provides quicker turnaround time, requires less volume, and can test for more substances simultaneously. So a lot of advantages to using the liquid chromatography as opposed to gas, which again was mentioned in the package insert because it was a little bit older and had not been updated. I'm going to move now and talk about validity testing. So validity testing is tests that are done to try and be sure that the sample you have is legitimate. And a lot of point of care cups do have some limited validity testing, usually at least the first one listed here, which is temperature. They'll have a temperature gauge. If any of you work with this, if you've done this for very long, I know you've had a urine sample turned in that just came out of the refrigerator, even though the patient claims to have just donated that. So it's always something to check then to be sure it's body temperature. Other things that could be tested, pH to look at the acidity or alkalinity of the sample, specific gravity, which looks at how many things are dissolved in the sample and can often identify if a sample's been diluted. There's urine creatinine, which can also give us some information about dilution and potentially tell if it's human urine, because yes, some people will try and substitute animal urine. You can also look at things like nitrites and oxidants, which are other additives that sometimes people will use to add to the urine to try and confuse the test. And this can often work when we're looking at an immunoassay, because anything that could break down the molecular structure could make it so those puzzle pieces don't fit together. This comes into play when people want to beat a test. So if you Google how to beat a drug test, if you can see on this, I did a year or so ago, and I had 202 million hits in less than half a second. If you read just this first line on them, most of these are telling you to drink a lot of water. Well, that's because the most common way to try and beat a test is to dilute the sample. If done correctly, you could lower the concentration of the analyte that we're looking for below that level of detection, and so it would come up as a not detected or a negative. Because a lot of times in recovery space, they will witness a drug test, but in most all medical and clinical settings, we don't do witness, and so it allows patients an opportunity to adulterate their sample. Other things they may add, we mentioned vinegar, bleach. Those would change the pH and be seen, but there are reports that they could be successful in defeating an immunoassay type test. Other ones use someone else's urine. This is very common. Or use fake urine. There is actually a cottage industry of fake urine that you can go online and buy. I haven't seen anything where you can buy it with metabolites in it or with different substances, but you can buy clean fake urine online. Another topic I wanted to cover was pill shaving or spiking. This is when a test is not supposed to be negative. We mentioned the false negative we had as a case study with the Vicodin. If a patient wasn't taking it and wanted to pass their test in office, they could actually have a little bit of the tablet and put it in the urine sample. And this now you'd have all of the parent molecule, the hydrocodone, in there, and that would allow it to pass an immunoassay. That test would be very positive. However, if you send it for confirmatory testing, we could potentially find something out. And I've got a couple slides on that in just a minute. We want to look at the validity testing, and this is how we would report our validity testings. We have three major ones that we do. I want to be sure we cover things like abnormal does not mean that someone cheated. The normal is a range. It's based on package inserts and population norms, and some people are always going to show up as abnormal. Then you have to see that there's a difference between being abnormally high or abnormally low. If you're abnormally high, like this example at the bottom, that means that things are more concentrated. A higher specific gravity and a higher urine creatinine would mean things are more concentrated. Now, the urine creatinine, if it was isolated as high, it might mean that they were using a non-human urine or some other type of urine to do this. But with everything is looking high, we can see how this patient has done in the past, and we can get a good idea of how it's going to be. If it's a low specific gravity and a low urine creatinine, this could mean it was diluted, but it doesn't mean it was intentional. A lot of people like to drink water for their health. They might drink alkaline water now, which has become popular, again, for their health. These things can dilute the urine the more you drink. You often have a patient maybe that came in one time and said they couldn't pee and waited around for an hour or so, drank water, tried to pee. So they may prep for the next visit by drinking a lot of water. This would dilute it. So it doesn't always mean it was intentional. And it doesn't always mean we can detect all attempts to cheat, like the pill shaving or fake urine, but that's where other testing comes in. So one reason we like to test metabolites of things is to know this. So if we're looking at a molecule like oxycodone here, oxycodone is broken down in the body through two pathways in the liver, the enzyme CYP3A4 and CYP2D6. Now, 3A4 would change it into noroxycodone, which is an inactive metabolite, and the 2D6 enzyme would transform it into oxymorphone, which is an active metabolite and is also another prescription pain medication. So we have a parent and we have the two metabolites there at the bottom. So if they had done pill shaving or scraping, a immunoassay test would light up positive, and that is all you would know is that the sample was positive for an opiate. With liquid chromatography, we're going to look at actually all three of these. And so we would probably see oxycodone, noroxycodone, and oxymorphine in the sample. It would be unexpected to have only oxycodone. If all I saw was a high level of parent and no metabolites, that would raise a red flag. Doesn't mean for sure that it was pill shaving, but it would be something I would question. If there was only oxymorphone, I might question if they had taken that instead. But if I see any mixture of the two, if I have two of these or if I have all three, then I know at least they weren't doing any pill shaving. I'm going to move now to ordering and interpretation. We got a few things. So ordering questions, as far as what type of testing to order, well, it depends on a lot of variables. So again, we talked about the benefit of immunoassay in the office is an immediate result that you can actually start acting on, and then you can potentially send that sample for confirmation elsewhere. But sometimes you may not need results then, and you can skip over that step and just simply do confirmation. And then there's some kind of in-between ones, which we can get to when we look at like what our rec form in particular looks like. I get questions about what analytes to order. That's definitely one I cannot discuss with you because it depends on even more variables, and it would be considered a conflict of interest for me telling you exactly what to test for. What I can do is answer questions, and I do all the time. So may get asked, why is a certain analyte on our menu? And I can discuss where we're seeing it be abused, what the latest data on it is, but I still can't tell you this is what you should test. So the last one is how often do I test? And this one, I can offer some guidance on because we do have documents that say when you should do it. Specifically, CMS does a good job of talking about how often that they will actually pay for definitive drug testing in chronic opioid therapy and in substance use disorder. So there are guidelines from CMS. ASP has been out there with some guidelines. There used to be a couple states that had guidelines to talk about how often we could test. So this is what our rec form, our menu requisition form would look like. This, probably something similar from whoever you might be using. This is what ours looks like. I'll draw attention to a couple sections because I want to talk about. The first is this kind of top where we have an order selection. This is more along the lines of I consider it a testing strategy. So you could click one of the buttons to order everything. We have two different reflex options. So in those options, we would do a screen. And then if something was inconsistent, further testing would then be done by confirmatory testing to determine the reason for that positive. So we would test some things through the LCMS to then, again, to dig into it further and hopefully understand the situation better. Over on the left side, you'll see our presumptive screen. So these are the things that we screen for. So we have a 15-panel screen. And then because we worked with clinicians that said, I don't care about ethanol, I don't care about THC, we give the option to not test for those. And then the rest of this, the bulk of this, is our definitive testing. And it can be ordered a la carte in as many individualized and customized options as possible. You could click on a class and it would then select everything underneath it in that class. You can uncheck boxes. You can check one thing at a time. You can look at just things that patients are prescribed. But I always encourage to look for something because, again, it's a lot easier to beat that test if the whole goal of the test is to be clean and to be negative, because then I can get fake urine online. Then I can get someone else's urine that's clean. But if you are testing for anything, just even what they're prescribed or looking for one thing that's supposed to be there, it almost universally will eliminate the ability for them to use a fake urine. And even the fake dilution, if they dilute it to the point that something that's supposed to be there is gone, that also could be a red flag. We talked briefly about other testing matrices. So this is from the American Society of Addictive Medicine. When to use blood, breath, oral fluid, urine, sweat, or hair. Some differences. Usually the biggest difference is how long something is detectable. So blood and oral fluid are very brief. You can usually pick them up really quickly, and then by the time you've got around 48 hours, most everything is gone. Urine, they say, is about 1 to 4 days. I usually think of it as 3 to 5, but we already discussed some of the really outliers that may be less than 24 hours or maybe a month or more. Sweat and hair can go longer, but you run into problems there about secondhand exposure. There's not as much data on how to handle that and how that gets taken into account. With hair specifically, we don't really know how a lot of hair care and those kind of things can weigh into this. So there are issues and pros and cons with each of these, much like everything else in life. A little bit on oral fluid. So this one is probably the second most common when we come to toxicology. It uses saliva instead of urine. Testing panel may have some limitations. We'll look at our rec form. There's only a couple very small limitations where we can't do the isomer testing on methamphetamine, and we don't test for an alcohol metabolite right now. The biggest thing to know about it is it has a shorter window of detection, just like we had on the ASAM document. About 1 to 2 days is all you're going to be able to find for most substances. However, it's much easier to collect. The patient say they can't produce urine if the provider doesn't want to or can't collect urine in their office. And the newest way this has really become popular is telemedicine. So if you are dealing with a patient remotely and doing telemedicine, you cannot ask them to do a drug toxicology test on video, and there's no way to witness it. There's no way to look at anything else. However, you can send them an oral swab. We even have kits that can be sent directly to the patient. And so during your telemedicine appointment, they can simply put the swab in their mouth, do the collection, witnessed during the appointment, and then you can have a toxicology test. So a lot less chance for the patient to cheat. There's not like a cottage industry in having fake saliva, at least not yet. However, there are some instructions on when and how to collect, and be sure we follow those. There is less published data, but it has been growing rapidly. And in fact, the Department of Transportation now accepts saliva testing, though urine, as we like to say, remains the gold standard and probably will for some time. This is our oral fluid menu. A lot less options at the top because there is no screening. We don't do any screening for this, but there is the full menu in its breadth, which actually has every analyte that we test for in urine and a couple of additional ones, but also a couple of limitations. If we look at results real briefly, this is what our results look like, probably very similar to other places. The first key is what are the reported medications? So for this particular patient, reported to be on Suboxone and gabapentin. And so then we go through what has been consistent. So we found something prescribed that's consistent, although this would cause me a little bit of a question because in this case, you can see the norbuprenorphine, the metabolite, was not detected. And this could be indicative of pill shaving, or it could be just the way this patient metabolizes the medication. Next, you would see an inconsistent result with a medication that was listed as prescribed but not found. So in this case, gabapentin was prescribed but was not detected in the urine. So that would raise a red flag. And then finally, we see two things that we detected that were not prescribed. Both of these, if you're unfamiliar with kratom or tianeptine, are quasi-legal in most areas. A few areas have them outlawed. Kratom is an herbal supplement, and then tianeptine is actually an antidepressant in some countries, but is often sold in gas stations, and people use it as a quasi-legal high. Finally, you would see results from specimen validity testing. This patient was slightly alkaline. Again, doesn't necessarily raise any red flags. This doesn't mean they put bleach in it. I would love to see other historical results, but we only have this one on this patient. So this one, other historical results would show up here, and we will be able to compare and look and see about how things went. The rest of the results would simply be an annotated list of everything was tested and if it was consistent or inconsistent. So you can see on the right-hand side, buprenorphine and norbup were considered consistent, even though the norbup was not found. Because the buprenorphine was, it would still be consistent. And then tianeptine was found, and that is inconsistent. So with that, I'm going to summarize and say where the clinical value lies. I think toxicology allows you to know if your patient is taking the medication they are prescribed. They can help identify a patient's attempts to self-medicate with prescription or illicit substances. They can help recognize a treatment failure versus an adherence issue. Because we know with most mental health meds, patients, only about 50% of patients are still taking it as prescribed at 1 year. Patients can use these results for peace of mind. So someone who's an addict can show that they're still on the path of recovery. A pain patient can show that, yes, they're continuing to take the prescribed pain meds. And again, a mental health patient, a psych patient could say, they're adhering to their mental health medications. But it's important that you recognize the strengths and weaknesses of the various testing methodologies. And if you do not understand a result, please reach out to your lab provider. Now, it'd be great if that was us. If it's not us, but you would like it to be, then we can talk about Jody, who is on here and will step up. And here's her contact info. She's our VP of sales, and she would be able to answer any questions about logistics, and I'll be able to take any questions about clinical issues. And while she starts talking, I will look and see what questions may have been asked during the talk, and I'll be back to answer them in just a second.
Thank you, Scott. I appreciate that information every time I hear it. I learn something new. I think it's a great reminder, too, just for everybody on the line. When you think about who we are as a lab, we obviously process a specimen, but the reality is that we're passionate about education, awareness, and we really view ourselves as a resource for everybody in the community. So I want to make sure you guys have our contact information. We really are focused on having a national presence, but a local feel. And that's absolutely what you receive when you partner with us. And Scott is just one of those examples, and the investment and time we make in education, because we think it's critical, not just that people test, but they understand why. And so we're here to help and support in any way that we can. And please take my information. I've heard every question in the book. I don't know all the answers, but I certainly know how to get you the person that does. And our teams across the country are ready to help and support in any way that we can. And it could be just a conversation of curiosity about what you currently do, what that means, what differences could be, or even just understanding how the process could be improved. So we are here to help in any way that we can.
Thank you, Jody. And we actually do have one question. I am going to stop sharing my slides, I believe, so that we don't need that. All right. Now, hopefully you're not seeing slides now. So we did have a question. Looks like Tiffany asked, how high can we quantify buprenorphine levels? So currently we are looking at, we max out around 400 is our maximum that we could quantify there. Interesting question. I don't have the ability to actually have a conversation with you about this. Maybe you have higher doses and are looking to have something that would quantify it higher than that. I have not found enough data that would say you could tell if someone was taking it as prescribed based on a level there, because so much can change with the patient's hydration status, when they took the last dose, when the urine sample was collected, which is, again, why it could never replace therapeutic level monitoring. All right, got another one. I like it. I have a UDS positive for alcohol, so ETOH, and the metabolite on a confirmation panel. So the patient denies alcohol use. Is the patient lying? And they state they use alcohol swabs for hygiene purposes. So I would want to see the alcohol swabs, because usually alcohol swabs are not ethanol. The rubbing alcohol most commonly used is going to be an isopropyl alcohol and would not interact with this test. The ethanol, if it was on a screen, is pretty specific for ethanol, and the ETG, ETS, if those are the metabolites you're looking at, are very specific for ethanol. However, you can get an ETG or ETS positive through incidental exposure. Specifically, ETS can come from non-alcoholic drinks. Non-alcoholic wine contains a large amount of ETS, and there have been case studies where they've looked at people that could test positive from using an ethanol hand cleaner for sanitary purposes. They did find you could get levels plenty detectable, but it was in patients that were using it on an OCD level, and then people in healthcare that were using an ethyl alcohol coming in and out of patient rooms for cleaning there. There's also been some positives from accidental exposures from fermented foods that can sometimes cause one or the other to pop, but usually it's very low level that they could be. But your sauerkrauts and other fermented foods, kombucha, of course, actually does have some, if it's made improperly, will have alcohol in it. So those can also cause it. So there's a lot of ways we can do that. And we actually have some resources that we use with our clients. We call them fact sheets about our frequently asked questions. And this is a very commonly asked question. And so we actually do have a nice one-page educational piece. If you reach out to Jody, she can send it to you on interpreting ETS and ETG levels. All right. Not seeing any other questions, but I definitely appreciate everyone's time and attention. I don't know if Brad or Nicole or Jody have anything else to add, but.
Thanks, Scott. I'm thankful for everyone that joined. Jody gave the information at the end, but also even if you just want to reach out and ask any questions, Jody can also connect you to Scott if you reach out to her first. But it could be to work with Genesis. It could be to ask questions. It could be for one of our representatives to meet with you. Our big, hairy, audacious goal is national presence at the local field. This is just example of one with providing education, but we do have representatives across the country that we can send in to visit with you. So